Hello and good morning, afternoon, or evening, depending on where you're joining us from. And thank you for joining us for this press briefing by the Africa Centers for Disease Control and Prevention. My name is Wayne Musabayana, and I'm Head of Communication at the African Union Commission. So today we have Dr. John Nkengasong, who is the Director of the Africa CDC. And as usual, he's going to be talking to us and starting off by giving us the epidemiological update on the continent. And then he will also take time to brief us on issues concerning vaccines. And specifically, he will be delving into a mission from which he has just returned to Geneva in Switzerland, where he met the leadership of the World Health Organization, of COVAX, and Gavi and CEPI. And on that mission, there were actually a number of representatives from the African side, and the rest of that delegation consisted of Dr. Vera Songwe, who is with the United Nations Economic Commission for Africa. She's the Secretary General there. And then Mr. Benedict Orama from Afreximbank, as well as Mr. Strive Masiwa, who has joined us quite frequently before, and he is with the Africa Vaccine Acquisition Trust. So those are a lot of details that we are going to be getting today. But before we get to that, let me give you the contact details for the question and answer session. So after the briefing, you can send in your questions to that usual WhatsApp number, and it is +251 9455 02310. That's +251 9455 0231. And to be more specific on the issues that Dr. John is going to be reporting back on concerning that visit to Geneva, they were discussing these following issues. So they discussed access to vaccines. They discussed how to accelerate the access to vaccines. And they also discussed vaccine manufacturing. And these are issues that are really topical at the stage at where we are at regarding to the response to COVID-19. So let me not take up much more time and introduce Dr. John Nkengasong, the Director of the Africa CDC, for his briefing. Dr. John, good morning and welcome back. You have the floor.
Thank you, Wayne, and good morning to all of you from the Africa Centers for Disease Control and Prevention, which is a specialized technical institution of the African Union. At this time, I will share updates on the COVID-19 situation on the continent, and I will divide my comments, as always, into three. First of all, give you the state of where we are with the pandemic, and then secondly, discuss what we are doing with as Africa CDC to support the continent, and lastly, the situation with the vaccine and vaccination situation. So let us start with the epidemiological situation. As of today, September 16, all of the 55 African member states have reported about 8 million cases of COVID-19. Of that number, 7.4 million have recovered. And we have unfortunately recorded a total of 204,000 deaths. And if you look at that number of deaths, put it in the context of the global deaths, it represents about 4.4%. The following 5 countries in Africa are accounting in excess of 60% of the caseloads of COVID-19 as of this week: South Africa, Morocco, Tunisia, Libya, and Ethiopia. 3 countries have continued to report a case fatality rate that is above 5%, and these 3 countries include Egypt, Somalia, and Sudan. We are not out of the wood yet. The third wave is still raging on the continent. As we speak, 43 member states, representing 73% of all of our member states, are now experiencing a third wave. And I'll come back to the third wave soon. Of that number, one country have been added to the list. That is Equatorial Guinea. 7 countries are now in their 4th wave, and I'll name them. They include Algeria, Benin, Egypt, Kenya, Mauritius, Somalia, and Tunisia. Since the last briefing, Egypt has now been added amongst the countries going through their 4th wave. So we continue to see that this pandemic is raging from wave to wave. For the 3 countries have detected the Alpha variant, 37 of them, of our 55 member states have reported the Beta variant. 37 other countries have reported the Delta variant, and 2 member states are now reporting the Gamma variant. Again, we should always interpret these variants or variants of concern as overlapping, that in some countries you actually may have all of them, and so it's not exclusive. So let us now look at the trends over the last week, that is from the period between the 6th of September to the 12th of September. During that time frame, a total of 133,000 new cases have been recorded across all 55 member states. And this represents a 20% decrease, average decrease over the last week. We continue to see high proportions of new cases in Southern Africa, East Africa, West and Central Africa. The following 5 countries are reporting the highest daily incident cases per million. So if you normalize it by the million, it gives you a slightly different picture. Seychelles, Tunisia, Botswana, Libya, and Cape Verde. In terms of death, a total of 3,400 new deaths were recorded over the last week, and that represents a decrease of 26% compared to the previous week. Let us now look at the last 4 weeks. That is the week between 16th of August and 12th September. During that time frame, we've observed a 14% average decrease in the number of new cases across the continent. Excuse me. The following trends have played out by the regions. 5% average increase in Central Africa, 17% decrease in Southern Africa, 14% decrease in Northern Africa, 7% decrease in East Africa, and 4% decrease in Western Africa. In terms of that, we've also observed a 14% decrease across the continent in the last four weeks. So the curve is definitely coming down, but we still have many countries that are experiencing that third wave. So let us now switch our attention to testing. As of today, over 69 million tests have been conducted across the continent. And last week alone, about 1.4 million new tests for COVID were conducted. However, that represents a slight decrease of about 5% compared to the last week. And the case positivity rate, the cumulative case positivity rate continues to be high. And as we speak, it stands at 11.6%. So let me now segue into our visit in Geneva. As Wayne said earlier, we had a delegation, what we call the AVAC delegation, the African Vaccine Acquisition Testing Delegation visit Geneva. That visit included Mr. Strive Masiwa, who is a regular guest on our platform, and he is a special envoy for COVID-19 on the continent. Dr. Vera Songred, the UN Executive Secretary General for the Economic Commission for Africa, the President of the Afri-Exim Bank, Professor Bernadette Orama. So that was the delegation. The purpose of our visit there was threefold. One was to discuss with the leadership of WHO, Dr. Tedros, the leadership of COVAX, Dr. Seth Berkley, and the leadership of the World Trade Organization, Dr. Ngozi, to actually, and others, the leadership of CEPI, Dr. Richard Hatchett, to discuss three things. One, how can we accelerate the situation of access to COVID vaccines on the continent, which I will touch on after this. The situation continues to be extremely critical and worrying for the continent of 1.2 billion people. The second thing was, how do we work to begin to accelerate the process of vaccine manufacturing on the continent, especially that component was discussed both with the WHO, the World Health Organization, and the World Trade Organization, Dr. Ngozi. And lastly, vaccine delivery. So we now know that with the AVAT mechanism, vaccines are beginning to be delivered on the continent, but how do we make sure that those vaccines get into the arms of people in a more coordinated fashion? I must add to this that Dr. Chidi Moeti, the director of the regional director of the World Health Organization for the WHO Afro office, was also part of the press conference, not necessarily part of the AVAT delegation. So I must say that it was a productive visit in terms of agreement and alignments in vision. One of the main outcomes of that was harmonizing our positions with respect to what we actually need now to achieve as a target in order to bring this pandemic under control. If you recall, last year we have stated that as a continent, we needed to immunize up to about 60% of our population to achieve herd immunity. That was the understanding at that time. With what we now know with the virus, that the vaccines that we are receiving do protect us from disease progression, from severe disease and hospitalization and deaths, but not necessarily against transmission. So we needed to regroup and revise that target. We agreed commonly that 70%, immunizing up to about 70% of our population, what will be of the total population, will be a reasonable target and an important programmatic target in order to produce the appropriate benefits for the continent. So I think that was a major outcome. So going forward, we align our goals and target and work towards achieving, and work towards achieving that target. For instance, I was delighted that the WHO and ourselves are still pushing for at least the continent to acquire vaccines enough to immunize up to about 30 to 40% of its population by the end of the year. I think that is an ambitious target, but it's a target that if we are truly determined that we need to get this pandemic out of our continent, that is a reasonable target to try to achieve. We also discussed, as I said, manufacturing, that we will need to accelerate the process and then work with the spirit of an ecosystem. That way, it's not one country manufacturing vaccines and then nobody else does that, but then we work collectively so that the vaccine process, the manufacturing process is actually spread out, is regionalized, and then it is the whole of Africa approach in manufacturing vaccines. So in the coming days, we will be inviting entrepreneurs and working with the Afro-Exim Bank to really sit down and go through the detailed process of what does it really take, and inviting them to be part of this process. As you recall, about 10 countries in Africa are now aggressively pursuing vaccine manufacturing. And I think these efforts will actually help us move, not just focus on the fill and finish, but look at the entire ecosystem of how vaccine manufacturing should be pursued on the continent. So let me just conclude my remarks by giving you an update of where we are with the vaccine situation in Africa. As of today, a total of 167 million COVID vaccine doses have been procured by 53 member states. Of that number, 122 million have actually been delivered, that is administered. The total coverage, that is people that have been fully immunized by the two doses of vaccines, it stands at 3.6%, so which is extremely low compared to where the rest of the world is. There are some hopes across member states. Morocco's full coverage stands at 46%, South Africa about 18%, Egypt 4%, Tunisia 19%. And so I think there's hope that if we have access to the vaccines, countries can actually take that up and we will increase that gap. I must conclude by saying that next week, we'll begin to discuss, we'll gather at the UN General Assembly, the UNGA meetings, the usual annual meetings. That I really hope, and it is my wish, that access to vaccines for a low and middle income country will become a central stage. We'll take central stage for those discussions. The foundation and the principles on which the United Nations was built was to come together to resolve humanity issues such as this one. And this is, in my view, one of the greatest humanity crises that we're facing of our time. So I really hope and wish that this is central to the discussions that will happen at UNGA next week. Thank you, Win, and over to you.
Thank you very much, Grant, for that update. Thank you very much for that update, Dr. John Kengasong. I seem to be getting feedback. All right, I think now we're okay. Thank you very much for that update. Let's dive straight into the questions. And you spoke about access to vaccines. And our first question is on that. It's coming from Judith Akolo, who is with the Kenya Broadcasting Corporation in Nairobi. And she says, my question is, testing for COVID-19, especially by the private sector, is prohibitive in Africa. So what can member states do to bring down this cost, as well as to ensure that testing is free of charge, so as to encourage more people to test? And she says she believes that this will be advantageous to the respective governments and to the Africa CDC, as the real situation of the disease on the continent will then be known and hence allow for targeted interventions. So that's the question from Judith of KBC.
So Judith, you are absolutely right. The cost of testing for COVID across the continent continues to be prohibitively high, and I'll say unnecessarily so, because we know the cost of reagents for the PCR test is not $100. The cost is way below that. I think it is really, the cost is actually below $10. So even if you factor in the cost of labor, it shouldn't take you up to $100. So we have been surprised to see this large fluctuation in the cost of testing across the continent, which actually will not encourage people to go to the testing stations. In the coming weeks, as I indicated earlier, we will be launching a massive campaign for surveillance, but using the antigen tests. Okay, so that we can empower the communities to move the testing into the community. And people should test and know their status. If they know their status, they can actually take action by isolating themselves and protecting their loved ones and protecting the community. So that the PCR testing would automatically become something that people do to travel and not something that we do to understand the epidemiology. So that is our goal in the coming weeks, and we hope once we launch that, we will enjoy their partnership and support as always, so that a large number of people should be tested in the next couple of months and know their status. I think that is what I would say with respect to that question.
Thank you very much. Online now, I'll say hello to Gabrielle Steinhauser. Good morning, Gabrielle. Please go ahead with your question.
Hi, thank you so much. My question is relates to the meetings in Geneva and more broadly. Do you feel that the countries that are now donating vaccines to Africa, and as well as the shipments that are now arriving from COVAX, is there enough support for countries to actually then get these doses into arms, both in terms of communicating to the public that these are arriving and that they're safe, but also, logistical and operational issues such as cold chain infrastructure and other others, or should the countries that are donating vaccines actually be doing more to support the distribution as well? Thank you.
I think both, Gabriela. We should be looking at both sides of the equation, the vaccine delivery and the vaccination process itself, because they go hand in hand. And countries are really making a lot of progress. I think we have discussed this over and over during this platform, and we have images to show to back this up. If you look at Morocco, Zimbabwe, Rwanda, and all these countries, and they have long lines of people sitting out there waiting for vaccines. So I think we really have to do two things. One, aggressively continue to work with countries, and that is what we are doing. Africa CDC has teams that are out there working with countries to strengthen the ability to deliver the vaccines, work with countries to strengthen community engagement and engaging with religious leaders. A team from the Africa CDC just returned from Cameroon, where they were meeting with the Muslim community leadership, the Christian community leadership, just to encourage them to work with us so that they can improve uptake of vaccines in the community. We have to do that. Logistics is a key challenge here, and we have to focus on that. Human resource capacity for vaccination is key. Well, we have to focus on that, and we are focusing on that, and many others. And that is one of the things that we discussed very specifically at Gavi with Seth Berkley, the CEO of Gavi. And it was really focused on how do we unite our efforts at ground zero and work with others to make sure that we deliver more effectively and more efficiently. I think that component, everybody is aware of that. For example, to be very specific, we said at Gavi that, look, if we know where your cold chains are, that you've put cold chains, then we can work on the maintenance of those cold chains. Africa CDC can work with you to maintain those cold chains so that they don't break down. And that would be a very good example of partnership, because we have boots on the ground, we can do that. So I think I remain hopeful that if the vaccines arrive, they will be put in the arms of people. Will everything go into the arms? No, but we have to work in mitigating that risk so that the loss of vaccines is not significant. I think we should really try to get all vaccines into the arms of people as much as possible. With respect to delivery, my appeal, and this is also something we discussed in Geneva, is that donation should be coordinated so that we know exactly what type of vaccine is coming, or when are they coming, and what is their expiration date, so that the country can plan accordingly. So you don't, it is in nobody's interest that you make an announcement today that you delivered millions of vaccines and the vaccines expire, say, in 3 weeks. I think nobody has the capacity and ability to get organized in 3 weeks to get people immunized at that scale. So I think it's a continuum of process and a continuum of dialogue. We continue to engage with all the stakeholders and everyone else who wants to work with us in this space. And I'm very pleased that there was full alignment during our visit in Geneva in this.
Thank you.
All right, thank you, John. And now we go to a question that's coming from our WhatsApp platform. And this is coming from Nicholas Barrio, who is a correspondent with the Wall Street Journal in Kampala, Uganda. He says, my question is about COVID-19 excess deaths in Africa. Statistics about excess deaths since the outbreak of the pandemic suggest that the real death toll from COVID-19 is many times higher than the official figures across many African countries. With these deaths likely way higher, what does this mean for the real impact of the virus in Africa? And how does this impact the case for vaccine equity?
So I think that is an area that I truly can have a conversation on. I don't believe that we have a significantly higher number of excess deaths in Africa. I think that we can dispute that. What we know for sure is that we have excess number of infection. There is people that have been infected and we didn't count them, okay, or countries didn't count them. And we have provided evidence to support this, right? We have shared evidence on this platform based on serologic surveys, which asks a basic question as to, have you been infected or are you currently infected? I'm using serological markers. We clearly reported that many more people have been exposed to the virus, but not dead. So I think that is one thing. The second part of the question, which is what you are addressing, is have there been a significantly higher number of deaths than what is reported? And I guess the answer, in my view, without the evidence, is no, based on sociological and cultural context. Deaths in Africa are taken seriously. If there are deaths in my village in Cameroon, I will know. I mean, for period. I mean, if there are deaths in your village in Kenya or Uganda, you will know. So I think that is absolutely, Africans don't hide deaths. It's a cultural thing, and we will definitely know that. Are we missing are the 204,000 deaths that we have recorded exact? Absolutely not. When we count things, we miss things. And that is basic public health and epidemiology. You count things, you not count everything. Are we missing it like 3 or 4-fold? I doubt that we are missing it by 3 or 4-fold. So we were also very clear during the peak of the third wave, where we saw large number of barriers went on. We reported that, and I think that was a very, very clear. But that is not what we are seeing on a daily basis across the continent. Now, when these waves come, they come with a severity. So let me just give you an example. During the third wave alone, which started from June to end of August, there were 72,000 new deaths. 72,000 new deaths out of the 204 cumulative deaths that we have recorded since the beginning of this pandemic. Just during the third wave. So that is how brutal the third wave these waves can be. So because they overwhelm hospital systems, even people die from things that are not necessarily COVID related, just because you may have a heart condition, and because all the beds and facilities are occupied, you actually die because of other things, not because of COVID. So the waves actually come in with a severe burden on the health system. They bring a serious impact on that. And as I said, 72,000 people died just over the last 3 months during the third wave.
Thank you very much. Let's go online and call upon Paul Adepoju. And Paul is reporting for The Lancet and Nature. Paul, good morning. Please go ahead with your question.
Thank you very much, and thanks for this opportunity. And during the visit, Dr. John's visit to Geneva, and in his presentation, and I began to ask about why are we not having a similar HAVAT approach to testing, because a country like Nigeria with nearly 200 million people, more than 1 year since the pandemic began, has not conducted up to 3 million tests. And there are also concerns around the trust, how people can trust the results that are coming from these tests. Let me give you 2 quick backgrounds. There was a news in Nigeria that when some Nigerians traveled to Ghana with a negative COVID test, on arrival, they will say that they tested positive, so they have to be paying $100 per night during quarantine. And these are really eroded trust that maybe the results are not reliable. So personally, in Nigeria too, I decided to explore this further. So I did 2 sets of COVID tests in 2 different laboratories. The first lab said I tested positive, and the next day I went to another lab, and that result said I tested negative. And currently I'm in the UK, where on arrival my day 2 test results showed I'm negative. So we can, so there are these concerns around trust of the COVID test seems to be quite valid. And so I would like to know what is being done to improve trust system in the COVID testing. And taking the question on testing further, what is currently the level of trust such that, in addition to bringing down the cost, antigen-based tests are being used so that the cost is brought down and it becomes available? A second question I have is on the recently released results of Ebola vaccine study in Syria alone that shows that is well tolerated and safe for users as young as 1 year. So I would like to know your remark on the outcome of these studies. Thank you very much.
So thank you, Paul. First of all, let me start with you actually asked about 3 or 4 questions in your 2 questions. I mean, let me start with the expanded testing in Nigeria. It's not only Nigeria alone. You've heard me on this platform over and over asking for testing, that if you do not test, you do not find. And the only way that you win an infectious disease, your fight against an infectious disease is to test. Okay, you test and you find out, you know what it is that you are dealing with there. And that is why, as I said earlier, in response to one of the colleagues on this platform said, we will be launching a vast campaign of testing, rolling out testing. Access to tests is not longer an issue now on the continent. It was an issue 1 year ago. It is not an issue anymore because there are so many products out there, good quality products for tests to conduct PCR testing. Just 4 weeks ago, we were in Morocco, and there's a company there that is producing quality, top-notch PCR tests, which will be encouraging African countries to buy a lot. I think the test costs about $5 or so, or less than $10, just to be, not to be very, very specific there. So we encourage all countries to ramp up the testing, but to expand the testing and not just limit it to people that are traveling, and to use it more to find cases, what we call surveillance, so that you can actually detect people that are infected and don't even know their status, and then let them take personal responsibility. That's the only way we are going to bring back this, beat back this pandemic. Because as we've discussed, vaccination rate is very low. We are at 3.5% with respect to those who are fully vaccinated. So it means that our public health measures, which is underpinned by large-scale testing, must still be encouraged. With respect to the validity or trust of tests, as a virologist myself, we lay a lot of emphasis on quality assurance. That's why we've worked very hard with the African Society for Laboratory Medicine, commonly called ASLM, to expand quality assurance programs and to train, and continue to train on quality assurance programs across the continent. So again, we have to make sure that the labs that are authorized to test do implement quality assurance, and it's only authorized laboratories that are conducting the test. Just excuse me. We believe that except we all collectively work together, that is, countries only allow specific tests, specific laboratories that are fully certified to be to conduct the test, that those laboratories conducting tests enroll in continuous quality improvement processes, and that there are checks and rechecks. It will continue to have issues. It's not only for COVID testing. Anything that you do in the laboratory requires aggressive quality control measures. So I think there's need to continue to enhance that, admit that there's some limitations when you do testing. It's not just for COVID testing. We're testing across the board. We've lived with HIV for 40 years, and we still continue to enhance quality assurance programs for those so that we ensure reliable test results. With the Ebola vaccine, I don't think I fully understood it. Was it that the vaccine is effective in younger age population, or can you just ask that question again, Paul?
Yes, the results show that users as young as 1 year can take the vaccine and it's safe and effective. So I want to know what you believe the outcome of these findings mean for Ebola response in Africa.
No, that would be huge. If clinical trials have been shown to demonstrate and back that children that are that young should receive the vaccine, that would be wonderful news. I think the most important thing is that we should back up our programmatic decisions based on evidence and science. So if those studies have been conducted in children, there is absolutely no reason. There is really no reason to believe that that should be the case and should actually become policy. The issue with children and Ebola is that, of course, they are infected. So if they are infected and they are vaccines that can be administered at that age group, then it means that we have actually expanded our toolkits to fight an eventual Ebola outbreak, especially using ring vaccination if these vaccines are available. So you'll not be restricting it only to adults, but to children. So that would be very encouraging results.
All right, thank you very much. Let's go back online and welcome Sophie Mukwena, who is with SABC. Good morning, Sophie, please go ahead.
Thank you so much. Dr. Nkenkesong, when you were addressing the media briefing on Tuesday with the WHO director and Mr. Masiwa, one issue that I picked up was that it looks like our strategy as a continent in terms of access to vaccines has been pushing very hard at international level, different international platforms to push for TRIPS waiver, which is actually a long-term goal, or one can say perhaps the aim. But in terms of objective, what we can achieve now to speed up access to vaccines, it looks like we were off the mark. I mean, the president of France also indicated that yes, TRIPS, but come up with a clear program for now, what you want and how to achieve that in terms of access to vaccines. The same with President of the United States of America, Joe Biden, at the G7. Now you have Biden, who has organized a sideline meeting on COVID-19 or conference or summit ahead of the United Nations General Assembly. And you also have the G20 meeting coming. Our president, President Ramaphosa, is leading the campaign on the continent to fight COVID-19 access to vaccines. He is also a co-chair of COVAX. He is a member of, South Africa is the member of the G20. We are also part of the UN. We might be participating at the summit with Joe Biden. What is your advice? Don't you think it's time for us as a continent, leading the charge, the president of South Africa, Cyril Ramaphosa, to change the gear and come up with something that can be immediate? The objective, the long term of TRIPS waiver, it's fine, but let's push the objective now, what we can do. And clearly the objective will be to push that pharmaceutical companies must release stock, because Strife Masiwa is saying we have money, but we can't buy because they are not making vaccines available to us. When we see big nations producing these vaccines, why are we not changing the strategy? Come up with the objective. We'll deal with the aim later.
So I think, Sophie, you touch on very key issues, on which, trust me and believe me, we are dealing with all of those issues simultaneously. We are not dealing with the waiver issue separately from access to vaccines now for the continent. I must say that, and I'll say this very clearly, that we need transparency in who is producing vaccines and where are the vaccines going to, because you hear all kinds of versions that the vaccines are not available, but yet countries are vaccinating. Okay, I mean, developed countries are vaccinating and achieving high percentage coverage there. So we don't know where these vaccines are coming from. And we have money on the continent, we don't have access to the vaccine. So it's really not a money issue. You've heard from Mr. Masiwa said many times that this sharing is not our solution. Tell us where the vaccines are, we'll go buy vaccines for our people on the continent. And I think that message has been very consistent. I mean, we welcome all donations, but that is not going to provide us the long-term solution to solving our problem. The president of South Africa, President Cyril Ramaphosa, has been an extraordinary, exceptional hands-on leader in this crisis in two ways. This is absolutely a technical and public health position that I'm laying out for you with clarity. One, it is through his push that he was able to, we were able to at least begin to achieve waivers. The United States came up, President Biden, remember a few months ago, saying the United States agreed to that. So it was because South Africa had taken a position, and the African Union endorsed that position and moved that forward during the February summit. I think we have a record for that. It is because of his championship that we got there. Second, the 400 million doses of vaccines that we signed with Johnson & Johnson that have started being distributed from the Aspen facility in South Africa is actually thanks to his personal hands-on engagement in the process. it's a long story, but he and Mr. Masiwa have actually been my true heroes in this battle against a COVID vaccine access on the continent. I usually, in a light manner, characterize them like the COVID warriors, the COVID vaccine warriors for the continent. They are truly our COVID vaccine warriors because they have been personally engaging with Johnson & Johnson and the Aspen Pharmaceutical Group in South Africa to make sure that we have these vaccines delivered in Africa. And we've been talking to all vaccine manufacturers, all of them in Africa, including anyone who wants to sit down and talk to us. We have been talking to them. So it's not like we're waiting for the waivers to come in, which will take time, as you say, and then we wait for these vaccines to. We are hands-on. We are actually working with everyone who wishes to work with us.
Thank you very much for that. Let's go to a question that's coming in from Adis Getachew. And Adis is the correspondent for Anadolu News Agency. So he says, could you please tell us what the challenges of having to use different vaccines in Africa have been in terms of tracking how many people took which brand? And then he also asks about the challenges, the logistical challenges, as different vaccines may require different ways of transporting, storing, etc. So those are two questions from Adis.
So there are only two vaccines that truly required an ultra cold chain. That's an ultra cold chain, just meaning that you need a minus 70 or 80 degree freezer to store them and then transport them to where they are needed. That is the Pfizer vaccine and Moderna vaccine. We know that for the rest of the vaccines have all been produced in a way that you can move them with the traditional cold chain, which is the 2 degrees to the 8 degrees refrigerator. So I think that is an issue that if I would say, and I've said before, that that shouldn't be an issue. If you gave me the Pfizer vaccines in Africa, I administer them in major cities. I would not move them into remote areas. So you make it a major city vaccine and roll it out in major cities. Major cities have power. They have deep freezers, and you can actually expand that very easily and monitor it and track it. Set up a system that you can track all of them so that you ensure that they are functioning well. So that is, in my view, not a problem. The challenge you have is predictable access to vaccines. And that leads me to your first question you asked is, all these vaccines coming in there. We cannot stop countries from accepting vaccines. We cannot stop the donors from donating vaccines, but they come in all kinds of forms. With the AstraZeneca comes, the vaccines come in, the Sinopharm come in, the Sinovac comes in. So it's all mixture of vaccine. All what we are asking, and this is what I said earlier, and we also discussed that in Geneva, is let us have at least a way to manage the collection of vaccines, the donation of vaccines, so that we can plan and support countries accordingly to deliver the vaccines and document who is receiving which vaccines and when are they receiving it.
All right, thank you. Let's move to our WhatsApp platform and say good morning to Sarah Jerving, who is with Devex. And Sarah says, on Tuesday, Benedict Orama said that $300 million is urgently needed with the target raised to 70%. And I think there she's talking about our initial prediction of needing 60% to achieve herd immunity. Then she goes on to say, will this 300 million be spent upfront as upfront financing for the purchase of vaccines? And if so, which manufacturer is the African Union in discussion with?
So I think President Orama, the president of the African Import Bank, was right. I think that is, as we shift our targets, I mean, the bankers have made their calculations and they said they will need an additional $300 million. And it could be applied towards any vaccine. It doesn't need to be the Johnson & Johnson or any other vaccine. We are looking for vaccines, effective vaccines, vaccines that have been proven to be effective and vaccines that are safe. All vaccines will be looked into. For now, do we have any company that is close to signing agreements with Harvard? No, we don't. Because again, as I said earlier, manufacturers are not, we don't yet have anyone who has come up and said, look, here we have enough vaccines and we can sign a contract with. Would the money be required upfront? The Afro-Exim Bank is ready to support those facilities. Remember, the Afro-Exim Bank committed $2 billion earlier on, and it is thanks to that commitment and that they were able to pay the Johnson & Johnson and countries bought into that contract. So I believe that if there's enough clarity of the course of action, the Afro-Exim Bank will be, and others will be ready to put on the table financing to support those additional doses that will be required to get us to 70%.
All right, we come back to Judith Akolo, who is with Kenya Broadcasting Corporation, and she says, my question is, we have noticed a slight drop in the number of new cases of COVID-19 with the positivity rate at 7% yesterday. And I think this is in reference to Kenya. Then she asks, can we comfortably say that the fourth wave in Kenya has plateaued and is now coming down?
I've not seen the specific data from Kenya, but if it is beginning to come down slightly, we hope that we'll see in the next 1 week or 2 weeks if that trend continues. And then we can rightly admit that we are beginning to bend the curve and plateau it for the fourth wave. But if you look at so that is the short answer to that question. But let's not fool ourselves with this, the peak and the troughs here. The truth is, if you look at the pandemic, the period between the first wave, the second, the third wave, and the fourth wave, it is usually an interval of 2 months to 3 months. So you come down to the trough, you can maintain it there for about 2 months or 3 months, and you go back upwards. So I think what we should be doing now is clearly working with member states to say, when we go down the peak, what do we really do? What are the measures that we should put in place so that we do not go back up there? Because if we keep doing the up and down movement, the impact on human lives is tremendous. I've given you some evidence. 72,000 Africans died during the third wave. So that we do not repeat that for the fourth wave and the fifth wave. It has tremendous impact on the economic toll that by these lockdowns, I think this the United Nations Economic Commission for Africa, UNICA, has in fact produced some figures which I'll find and share with you or next week, which speaks to how much damage it does to the economy by the lockdown. So we really have to be balancing between saving lives and saving economies, so that when we come down, when Kenya comes down to the trough, what do we do to keep Kenya at that level
thank you very much, Dr. John. We don't seem to have any more questions coming through. So perhaps let me then give you this time to summarize your key headline points for takeaways from today's briefing.
So again, my key points is really that as we gather next week at the United Nations General Assembly.
Hello, Dr. John.
Yes, can you hear me? Hello? Hello?
Hello, yes. I was saying that we don't have any more questions, so this would be the time for you to give us your summary of the main headline points.
So if you can hear me now, I was saying that it's just one point, that as we gather next week at the UN General Assembly, it is my hope and wish that access to vaccines on the continent should take central stage, because we cannot live in a world of vaccinated and the unvaccinated. That is not the formula to win a pandemic. We have seen what has transpired in Israel. We've seen what is going on in the United States, where a large chunk of the population is vaccinated and a large chunk is not vaccinated, but you see the impact that it begins to neutralize even the effect of the vaccination, what the vaccination had done in terms of protecting people from severe illnesses or severe deaths. So I think that will be the same thing. If the developed world is vaccinated and Africa is not vaccinated, you see the same effect happening there. So I think it is my appeal that discussion, a specific discussion of how do we quickly make access to COVID vaccines on the continent of Africa should be the central point of discussion for next week's UN General Assembly meeting.
All right, thank you very much for that. I will have to apologize to you because we have one question that's just come in, which I think we can take in the remaining few minutes before we run out of time. And it is coming from Mario Baptista. And he says, you said that Equatorial Guinea has been added to the countries facing the third wave. However, Equatorial Guinea's figures of 10 seems rather small. How do you explain this, given that there have been several organizations questioning the country's data?
So remember, this is the country's reported data, and it's not about the number of cases. It's you're comparing your 7 days moving average each time with a previous week. Okay, you are not. So we do not go to any country to gather data from that country. We work on data that is reported from the country. That is what everybody, all public health organizations do. So even if your numbers are low, we're comparing the numbers of the previous week and the numbers of this week, okay, to determine whether you are moving towards the third wave or the fourth wave.
All right, thank you very much. And that was our very last question for today. So let me thank Dr. John. He has already given us his summary. Let me thank you, colleagues joining us from throughout the world, and also thank you to the team behind the scenes at the African Union and the Africa CDC. Let us meet again for another press briefing next week on Thursday at the same time. Bye-bye for now.